In the name of God. Hello dear friends, this is Dr. Ashabi and this is fourth session of circulatory physiology. We're going to discuss volumes and capacities and characteristics of vessels. Then we will discuss capillary filtration, which factors affect capillary filtration and what is colloid osmotic pressure. And then we will talk about pathologic condition named edema and the role of vein valves on circulatory system. And finally we will discuss about blood flow control. So, what is the difference between volume and capacities of different vessels? Here you can see the volume of arteries are about 50 to 80%. The veins is about 60 to 65%. Capillaries is about 5%. Lungs volume is about 9%. And heart volume is about 4%. The summation of these are 100% and they are volumes or vessels. And capillaries are 11th division of aorta. It means that after 11th division we can see capillaries. After 8th division we can see arterioles, and after 11th division we can see capillaries from arteries. In here you can see blood velocity in different vessels. In arteries, velocity of blood is about 30 centimeter per second. In veins is about 3 centimeter per second, and in capillaries is 0.3 centimeter per second. So you can see low blood velocity in the capillaries because we need to exchange the gases and nutrients from the blood into the interstitial fluid, and also collect the waste and carbon dioxide from the interstitial fluid to capillaries. Because of that, there is a very low velocity of blood in the capillary. Also, you can see cross-sectional area in different vessels. For example, in aorta, cross-sectional area is about 2.5 centimeter squared. In arterioles is about 40 centimeter squared. In small veins is 80 centimeter squared. And the important thing in capillaries you can see is about 2500 centimeter squared, and you can compare it with the cross section of aorta or arterioles. Is a very high, so total cross section area in the capillary is very higher rather than other vessels, because we need high area, we need a very large amount of area to exchange the gases and nutrients and molecules between the blood and interstitial fluid. Also, transfusion pathways between blood and interstitial fluid might be done by capillary pores. We have some pores or fenestrates on the endothelial cells of capillaries. So these pores can transfuse nutrients, molecules from them to the interstitial fluid. The membrane of endothelial cell is another way to transfusion the molecules and especially gases from simple diffusion way. And finally, the pinocytosis or transcytosis is another way that molecules go to inside the endothelial cells by endocytosis and pinocytosis, and then went to interstitial fluid by exocytosis. It's named transcytosis. This way named transcytosis, that molecule pass through the endothelial cells. Based on the difference of endothelial cells in different organs of our body, we have different types of capillary. So some types of capillary are very tightly connected with each other. Endothelial cells are very connected with each other with tight junction. For example, in the brain we have blood-brain barrier, and this barrier is because of these tight junctions. It means that, based on, you can see in this figure, two endothelial cells tightly bonded with each other with tight junctions, and the transfusion of gases and molecules are very restricted in this way. So because of that, the delivery of some drugs is very hard to the brain. The other kind of capillary is very regular in our body, and it seems in many organs such as skin and muscle. They are having some kinds of pores or fenestrates, but they cannot transfuse large molecules. But in the third kind of capillary pores is named fenestrated or sinusoidal. These kind of capillary pores on the endothelial cells are large hole, and fenestra can be seen in the kidney, and because of that, large molecules can pass through these holes in the kidney, and we can see it. The other type of capillary pores are gap junctions, and the endothelial cells contain very non-specific pores and can helping for passing through some molecules, special molecules. We can see this kind of capillary in the liver organ. We have two kinds of capillary end, and we want to discuss capillary filtration and reabsorption in this slide. Imagine that arterioles will end to capillaries. The blood pressure of arterioles is about 30 millimeter of mercury. So this pressure of blood pressure of arterioles should go inside the capillaries. And also inside the capillaries we have another pressure that suction the blood. So we have two pressure that push blood into the capillaries. One pressure from the arteriole is about 30 millimeter mercury, and the other pressure that doing suction from the capillaries because of the negative pressure of interstitial fluid to the capillaries. And inside the capillary we have two ends. The first is arterial end, and the other one is venous end. Here you can see the arterial end in the left side, and venous end in the right side. In the left side and arterial end we have capillary filtration. What does it mean? Please see these digits in the bottom of figure. In the capillary we have two pressure. One of them is hydrostatic pressure, and the other one is colloid osmotic pressure. So we have two space. One space is in the interstitial fluid, in the yellow part of this figure. Interstitial fluid has both hydrostatic pressure and colloid osmotic pressure, and the blood inside the capillary has the two pressure too, the hydrostatic pressure and colloid osmotic pressure. So let's see what's the number of each of these pressure. The first one, blood hydrostatic pressure, is about 30 millimeter mercury, as I said, and this 30 millimeter mercury is out of the capillary. It means that it into the interstitial fluid. So please keep this 30 millimeter mercury out of the capillary. The other hydrostatic pressure is the pressure of interstitial fluid. The pressure of interstitial fluid, your interstitial hydrostatic pressure, is 3 millimeter mercury, and 3 millimeter mercury is in plus the 30 millimeter mercury. So the summation of hydrostatic pressure in the blood or in the capillary is 30, and in the interstitial fluid is 3. It means that interstitial fluid 3 millimeter mercury want to suck the blood. Okay, so imagine that 3 millimeter mercury is negative for interstitial fluid, and finally the summation of these two pressures is 33 millimeter mercury to out of the capillary or inside the interstitial fluid. So because of negative pressure of interstitial fluid in arterial end, we have 3 millimeter mercury out of the capillary. So let's see the colloid osmotic pressure. Colloid osmotic pressure is because of proteins and other agents that are in the blood or in the interstitial fluid. So let's see what's the colloid osmotic pressure in the blood and in the interstitial fluid. Colloid osmotic pressure of blood is 28 millimeter mercury. It means that the blood's cells, proteins, ions, and all electrolytes and agents tend to absorb fluids to a pressure of 28 millimeter of mercury. So it's against the 33 millimeter mercury. Okay, and also we have interstitial fluids colloid osmotic pressure. It means that the proteins and cells and agents, electrolytes in the interstitial fluid tend to absorb fluids for about 8 millimeter mercury. So it's against the 28 millimeter of mercury. So arrow is against. 28 is inside the blood or capillary, and 8 is outside the blood. And summation and difference of these two digits, 28 from 8, is about 20 millimeter of mercury inside the blood. Okay, so final summation of hydrostatic pressure and colloid osmotic pressure in the arterial end is 30 millimeter of mercury out of the capillary. So it's for arterial end. What about venous end? In the venous end, as you can see in these figures and digits, blood hydrostatic pressure is 10 millimeter mercury out of the capillary. Interstitial hydrostatic pressure is 3 millimeter of mercury out of the capillary too. Colloid osmotic pressure is 28 millimeter of mercury inside the capillary, and tissue fluid osmotic pressure is 8 millimeter mercury outside the capillary. Summation all of these in the venous end, like arterial end, is 7 millimeter of mercury inside the capillary. So there is a difference between arterial end and venous end. In the arterial end, by the difference of 13 millimeter of mercury, 16 milliliter of blood tend to go inside the interstitial fluid. Remember the digit. For difference of 13 millimeter of mercury, 16 milliliter of blood tend to back to interstitial fluid and go to interstitial fluid. It means that 13 millimeter mercury pushes the blood for 16 milliliter into the interstitial fluid. But in the venous end, for difference 7 millimeter mercury, 40 milliliter back into the capillary. There is a difference. in the arterial end, blood goes to interstitial fluid, and in the venous end, the fluids back to the capillary. And the difference of pressures and the fluids is very important. In the arterial end, for 30 millimeter mercury difference, we have 16 milliliter blood from the capillary into the interstitial fluid, and in the venous end, for 7 millimeter mercury, we have 40 milliliter blood or fluids back from the interstitial fluid into the capillary. Why this has happened? Why the ratio of 30 millimeter mercury and 16 milliliter is not the same of 7 millimeter mercury and 14 milliliter? We can say some reasons for this. One of them is that the pressure of the arterial end is 30 millimeter mercury, but this pressure and the arterial end is about only 1/3 of capillaries length. So only in 1/3 of capillaries length we have 30 millimeter mercury, and in the 2/3 of capillaries length we have 10 millimeter of mercury. And because of that, we can see these differences in pressures that can push the blood outside of the capillary or absorb the fluids from the interstitial fluid to the capillary. And also the permeability of venous end is higher rather than the arterial end. This is another reason, because of this, why we have different blood exchange in different pressure into arterial end and venous end. And the other reason is that in the arterial end we exchange or diffuse O2 from the capillary into the interstitial fluid, but in the venous end CO2 diffuse from the interstitial fluid into the capillary. And you know, the CO2 is more soluble rather than oxygen. Other things also are important. For example, at arterial end we exchange glucose, at venous end we exchange uric acid or ura, so the size of glucose is very smaller rather than ura and acid uric. So it's another reason for these differences between fluid exchange in arterial end and venous end. So for summation, in all of capillaries in our body, in the arterial end we have 16 milliliter exchange of fluid from the capillary into the interstitial fluid, and in the venous end we absorb 40 milliliter fluid from the interstitial fluid into the capillary. The difference of this is 2 milliliter. So in total capillaries of our body, 2 milliliter fluid is to the interstitial fluid, and this extra fluid will absorbed by lymphatic vessels and lymphatic system that we will discuss in future. Two milliliter fluid goes into interstitial fluid during capillary filtration, and this 2 milliliter fluid is collected by lymph vessels. What are lymph vessels and lymph channels? Lymphatic system could collect fluids and proteins from interstitial fluid and return them into circulatory system. If lymphatic system couldn't do its job, the body cannot be survived for over 24 hours. So here shows the importance of lymphatic vessels and lymphatic system in body. Lymph system could return 2 to 3 liters of fluid in a day to circulatory system. As you can see in this figure, lymphatic system has some channels and nodes. You can see lymphatic nodes distribution in our body, and also you can see lymphatic channels. Lymphatic channels has some characteristic. One of them is that they are dead end. In spite of vessels, lymphatic vessels are dead end, and also they are segmented, and each segment has valves, and these valves by 2 cells around them could produce a suction and can generate a automatic pump and suck the interstitial fluid into the lymphatic vessels. And also these valves, in spite of these valves, we have some holes in the beginning of each segment. So the high permeability of lymphatic vessels and production of automatic pump by contraction of the cells around the valves could collect interstitial fluid into the lymphatic channels. The suction of lymphatic pumps could produce negative pressure in the interstitial fluid, and so this negative pressure inhibits interstitial fluid edema or collection of fluid in the interstitial fluid and edema. And also lymphatic vessels are a scavenger. They can collect toxins, viruses from the interstitial fluid and bring them into kidney or liver for destroying these agents. So lymphatic vessels could collect large proteins that the veins cannot collect them. Also they can do as a scavenger, can produce negative pressure in interstitial fluid. And the other important thing is that even the pressure of interstitial fluid increase, the suctioning and the activation of lymphatic pumps increase too, to reduce the chance of edema in that organ. Lymphatic vessels collect fluids, and then left part of our body empty lymph fluids into left subclavian vein, and right part of our body empty fluids into right subclavian veins, and then they empty into veins and return fluid and proteins to circulatory system. There is a colloid osmotic pressure in the plasma. Some proteins could generate this colloid osmotic pressure that you can see in this slide. First of them is albumin. Albumin could generate the osmotic pressure around 21.8 millimeter of mercury. And the second important protein for colloid osmotic pressure of plasma is globulins, produce 6 millimeter mercury pressure. Fibrinogen produce 0.2 millimeter of mercury pressure. Total summation of these three important proteins for inducing colloid osmotic pressure is 28. A scientist named Gibsonan collects these three important proteins and measure their osmotic colloid pressure in the experimental lab, and he found that summation of these three proteins in vitro is about 19 millimeter mercury. So why there is a difference? Why in the body these three proteins produce 28 millimeter mercury colloid osmotic pressure, but in laboratory the summation of these three proteins produce 19 millimeter mercury colloid osmotic pressure? This named Gibsonan phenomenon. In this phenomenon, Gibsonan said that in our body the protein has negative pressure and positive ions bind to these proteins, and binding the proteins to cations and positive ions can increase the colloid osmotic pressure of the proteins, and because of that these three proteins has 28 millimeter mercury in our body. This phenomenon named Gibsonan phenomenon. If capillary filtration is not in stable and physiologic situation, and also the lymphatic system couldn't do its job, we can see edema in our body. Here I listed the reasons of edema in our body. First of them is increasing capillary pressure. Increasing capillary pressure because of high volume of salt and water in our body, high vein pressure, low arterial resistance could produce edema. Reduction in plasma proteins also generate edema. And why this situation is happen? Because of one important thing is that secretion of protein from urine because of kidney injury. Protein exertion from damaged or burned skin is another reason for reduction of plasma protein. Disability in protein production and also malnutrition is another reasons for reduction of plasma protein. Increased capillary permeability during some disorders like immunoreactions, vitamin C deficiency, long-term ischemia, poisoning, infection, cancer, surgical procedure may increase capillary permeability and destroy capillaries wall. The other reason for edema is lymph system occlusion. Some reasons for lymph system occlusion may be related to genetical disorders, cancer, increased lymph system occlusion, and also parasites like some disorders named filariasis can occlude lymph system, and then lymphatic system cannot do their own job and edema is seen. The other part is venous return disorder. Venous return disorder is because of deficiency in venous system, and blood inside the venous cannot return to the blood and to the circulatory system. Maybe the reasons are maybe hydrostatic pressure, valves disorder, and varix in our body. Physical and pathological occlusion may be reduce venous return and finally generate edema. As you can see here, the interstitial fluid volume depends on capillary pressure, capillary oncotic pressure, capillary filtration, capillary coefficient, and number of active capillary or lymph channels, and cellular fluid volume, and finally edema. You can see a person with edema in their body, and the edema, as I said, has some reasons, and physician should recognize which kind of these reasons is disrupted and then treat them. Here you can see the role of gravity on vessels pressure. As you know, in upright standing person, gravity has important factor on vessels pressure. For example, venous pressure in upright standing person in fixed situation is about 90 millimeter mercury, and the pressure near to heart is considered as 0, and pressure in their feet is considered as 19 millimeter mercury, and also the pressure in the head is considered as negative. For example, in the sagittal sinus, pressure is about minus 10 millimeter mercury. Also, this pressure is higher in the arteries. Why? Because arteries has already a pressure. For example, imagine arteries pressure is about 100 millimeter mercury. So by increasing the effect of gravity in the feet, the pressure of artery is about 190 millimeter mercury. So the pressure of arteries is higher in the feet. But this is not important as the pressure of veins, because arteries can send the blood into the veins. So, which factors helps venous to return the blood into the heart and collect the blood from the feet into the heart? As I said, hydrostatic pressure in the arteries is 100 or 120 plus 90 millimeter mercury, the pressure of gravity. But it's not important, because arteries should send blood into capillaries and then veins. But the pressure of veins is important. Why? Because veins should return blood against the gravity into the heart. And this named venous return. And venous return mechanism is very accurate. For example, one directional valves or vein valves is important in the vein, especially in lower part of body, in the feet, for venous return. How these vein valves helps for venous returns? As you can see in this figure, the valves are inside the veins, and they are in two sides of valve are connected with each other by movement or contraction of muscles. These valves are open and insert the blood into the upper part of the body. And by sending the blood into the upper part of the body, these valves are going to be closed. Why? Because of rebounding of blood on these previous valves. So these valves, in connection with muscular contraction, helps blood to go to the upper side of the body. And when blood goes to the trunk, the diaphragm, and the negative pressure of chest helps blood to return to the chest and return to the heart. Here you can see important factors that helps for venous return. First of them is venous valves, and the other important factor is cardiac suction effect, which decrease pressure in heart and increase gradient of pressure between venous and heart. The other reason for venous return is pressure imparted to blood by cardiac contraction. By cardiac contraction, venous return will be increased because of increasing pressure gradients. The other reason is sympathetic vasoconstrictor activity and increased venous return. The other reason is skeletal muscle pump that helps to vein valves and increase venous return. And respiratory pump is important, reduce the pressure in chest vein and increase gradient pressure. And finally, increasing blood volume will increase venous return and increase pressure gradient by, for example, salt and water retention or passive backflow shift of fluid from interstitial fluid into the plasma. All of these factors helps for increasing venous return. So finally, end diastolic volume will increase, stroke volume will increase too, and at last the cardiac output will increase. So you can see the effect of each of these factors on cardiac output. When a person suddenly change their position from laying down to upright position, the pressure of the head decrease, and because head is 50 centimeter higher than heart, the pressure in suddenly changing the position from laying down to upright position reduce the systolic pressure to 80 millimeter mercury. And this is important factor that when person want to change their position from lay down to upright standing or suddenly changing the position from lay down to upright standing. And when the person suddenly changing their position, we can see dizziness or vertigo in these patients or in these individuals. When a person suddenly change the position from laying down to upright standing, maybe dizziness is seen, but a person when decided to go to the upright standing, some physiological changes in circulatory system is happen, and because of that there is no reduction of systolic pressure in the head, and there is no feeling dizziness. What are these mechanisms? Here you can see these mechanisms that helps us to regulate our blood circulatory system. Blood flow controls by local control, general and humoral control, or central control. Let's look at the local control. Local control has two parts: short-term local control, long-term local control. When is short-term local control? Local control, it means that it happens, the blood flow control happens in one local part of body, for example in leg or in hands or in trunk or in any organs. And short-term local control is happened during, for example, during dipping the needle into the fingertip during sewing. Imagine during sewing when a needle dip into fingertip, we at first press the dipping side, and after some seconds of pressing the dipping side, there is no blood circulatory in that part, and then we feel some pain in that part, and then we release our hand from pressing the fingertip. After that we can see the blood flow increasing and warming that part, and also we can feel some pulse in that part. That is because of local control and short-term local control of blood circulatory system. This is an example of reactive hyperemia. Reactive hyperemia is because of blood flow after some occlusion, for example for ischemia or on even the press of fingertip. It's the backing the blood after any occlusion of blood flow. It's named reactive hyperemia. Active hyperemia is happening during any exercise or any increasing blood flow locally. So both of them are short-term local control of blood flow. Why this short-term is seen? When we press our fingertip, the blood circulation is disrupted in that part, so blood cannot bring the nutrients and oxygen into that cells, and the level of ATP will reduce in that cells. After releasing the finger from the press, the blood circulate in that area, and because of lacking ATP, the cells and the endothelial cells in that region cannot contract. So, and blood should flow in high pressure because of not contracting that part, because of lacking ATP. And that's why we see warming and pulse in that region. But what about long-term local control of blood flow? During permanent or chronic exercise or any reason that increase the blood flow locally, we can see long-term local control of blood flow. During long-term local control of blood flow, we can find growth factors enhancement in that part of body, and these growth factors helps to angiogenesis and increasing the capillary bed in that part. These are local control of blood flow. But what about general control of blood flow? And what about central control of blood flow? General control of blood flow consists of humoral control of tissue blood flow, and they categorize as two parts, vasodilator and vasoconstrictor. Let's see vasoconstrictors at first. Vasoconstrictors like epinephrine and norepinephrine are secreted from suprarenal glands, and they constrict vessels by high power. So they are most important vasoconstrictor during blood flow regulation. You know, epinephrine and norepinephrine acts through alpha and beta receptors. Alpha 1, 2 and 3, and beta divided to 1, 2 and 3. Beta 1 is acting on heart, beta 2 is acting in lung, and alpha 1 receptors is acting in vessels, and stimulation of these receptors induce constriction. And so some drugs that inhibit alpha 1 receptors may induce vasodilation. Another important vasoconstrictor is angiotensin II, AG2. Angiotensin II is important and powerful vasoconstrictor. During reduction of blood flow, kidney produce renin. Renin is important factor that is responsible to converting angiotensinogen to angiotensin 1. Angiotensinogen is inactive form. Also angiotensin 1 is inactive form. And angiotensin 1 circulate in body and go in the lung, and in lung by effect of one enzyme named angiotensin converting enzyme, or ACE. Angiotensin 1 convert to angiotensin 2 and act its vasoconstrictor effect in the whole body. The other important vasoconstrictor is antidiuretic hormone as ADH, and the other hormone is endothelin, and this is the other vasoconstrictor, and neurokinin Y. We will talk neurokinin Y in continue. So let's see vasodilators. Vasodilators, as you can see categorized in this table, nitric oxide or NO is important vasodilator, and NO is produced by endothelial cells and inhibit the contraction of endothelial smooth muscles and act as vasodilators. Also, when blood flow inside the capillaries, the RBCs scrub on the endothelial cells, and this scrubbing of on the RBCs on the endothelial cells stimulate endothelial cells and produce nitric oxide, and this nitric oxide is responsible for vasodilation. So NO is categorized as important vasodilator. So this effect of blood flow on the endothelial cells and this rubbing or friction of blood, especially RBCs on endothelial cells, produce a force named shear stress. Shear stress is the force because of movement of blood on the endothelial cells, and shear stress has direct relation with viscosity and velocity, and has a reverse effect with the radius of the vessels. Another vasodilator is CGRP, abbreviated as calcitonin gene related peptide. They are secreted from sensory neurons, and the sensory neuron secretion act as vasodilation in the body. Some neuropeptides, as substance P, B, neuropeptide A, neuropeptide B, they are categorized as vasodilators. Also, neurokinin Y is neuropeptide, but neurokinin Y has vasoconstrictor effect, as you can see in this figure. And some other agents such as kinins and histamines has vasodilatory effect. So these are the basic of humoral control of blood flow, and some drugs activate these agents or inhibit these agents by acting on their own or it's their receptor and doing the vasodilatory effect or vasoconstrictory effect. We have many angiotensin II or ACE inhibitory drugs, epinephrine or norepinephrine inhibitory drugs in the clinic. Third control of blood flow is central control of circulation. As you can see, there is our centers for blood circulation control in the medulla oblongata and pons. We have three parts. First, vasoconstrictor as C1, second, cardio inhibitor as A2, and third, vasodilator as A1. Let's start with C1. C1 is a vasoconstrictor center, and they are located bilaterally in the anterolateral portion of upper medulla, and this neuron from here originating and go to the spinal cord and excite preganglionic vasoconstrictor neurons of sympathetic nervous system. So do they act as acting sympathetic nervous system. A2 is vasodilator center. These neurons are located bilaterally in the anterolateral portion of the lower medulla. Fibers from these neurons project upward to the vasoconstrictor area, inhibiting the vasoconstrictor activity of this area and causing vasodilation. The third part is A2 control center. The cardioinhibitor center slows cardiac function by decreasing heart rate and stroke volume via parasympathetic stimulation of vagus nerve. So they acting through vagus nerve and activate parasympathetic neurons and induce cardio inhibition. How this central nervous system is controlled? They are controlled by baroreceptors and chemoreceptors. Baroreceptors is important. Here you can see the position of baroreceptor is in the purification of common carotid to internal and external carotid, and also in carotid arc. Baroreceptors are in all of our vessels, but they are more distribution and they are more concentrated in these two parts, as you can see in the figure. Baroreceptors, as I said, they are in internal carotid artery, in the wall of internal carotid artery, above the bifurcation of the artery, common carotid artery, named carotid sinus, and also in the wall of carotid arc. They are sensitive to oxygen changes from 60 above the 60. When the pressure of oxygen is started to increase, they are activate. And in the aortic arc, when the pressure of oxygen is above 30 mm mercury, they are started to activate. Signals from the carotid baroreceptors are transmitted through small herring nerves to the glossopharyngeal nerves in the high neck, and then to the nucleus tractus solitarus in the medullary area of the brainstem. Signals from the aortic baroreceptors in the arc of the aorta are transmitted through the vagus nerve to the same nucleus solitarus of the medulla. What about chemoreceptors? Chemoreceptors are located in the bifurcation of common carotids into internal and external carotid, and also in the aortic bodies. The chemoreceptors excited nerve fibers that, along with baroreceptor fibers, pass through Herring's nerve and vagus nerve into the vasomotor center of the brain. This reflex inhibits sympathetic fibers, activate vagus nerve, decrease peripheral resistance, decrease heart rate, and finally blood pressure. They are sensitive to pressure of oxygen and especially sensitive to hydrogen ion and carbon dioxide changes. My dear friends, if you have any question, please ask me.